So, going on, yeah. Mm. Basically, I need to finish respiratory system, and it'll take a bit. It'll take a bit, but that is the last topic in the Paka Pass series, and I will be able to make a grand video and just upload the entire thing. So that's one good thing. Mm. My thing is getting set up. I think new project. Okay, we're good. I'll unlock it in just a minute. Okay, so we're back and we are pretty much better than previously we were. So yeah, the only thing which I didn't do properly, I don't know everything. I feel only thing which I didn't do was about arthritis and stuff like that, which at this point I'm like, okay, I don't care. I've done majority of everything which is there in both these books, and yeah, in the starting part I didn't have my pen plugged in, so this part was a little bit. I feel my pen is having like very low charge, I think. So I don't know how long I can do this for. I'll just check a second. Yeah, it has like 1% or 2% charge. That's awkward. I'll just end this and I'll come back in a second. Not even like a second later. Yeah. Stream my thing. Mm-hmm. No, this is not working. Just as again, it's being connected to you. Okay. So going on, yeah, I was saying how literally everything has been done. So let's finally blood or bloody sputum. So you have types, which is frank, which is expectoration of blood only, as in bronchogenic carcinoma, foul smelling bloody sputum in suppurative lung disease, spirituous hemoptysis, wherein hemoptysis secondary to upper respiratory tract infection above the larynx, pseudohemoptysis due to pigment digoxin. What is this? Digoxin. Never heard of it actually. Okay, pseudohemoptysis. Then endemic hemoptysis is infection with Paragonimus westermani, which is liver fluke. So severity, you have mild, which is less than 100 ml per day, moderate, which is 100 to 150 ml per day, severe, which is up to 200 ml per day, and massive, which is more than 500 per day, or more than 150 ml per hour per day, or per hour, or 100 ml per day for more than 3 days. That is massive. 100, 100 to 150, 200, and more than 500. So it can divide as causes due to infection, neoplasm, cardiovascular disorders, traumatic, bleeding disorders, collagen vascular disorders. So infections, it can be TB, lung abscess, bronchiectasis, pneumonia, and fungal infection. Neoplasm, you have bronchogenic carcinoma, bronchial adenoma, and metastatic tumor to the lung. And metastenosis, pulmonary hypertension, aortic aneurysm, AV malformation, and pulmonary embolism can be cardiovascular disorders. Traumatic, you have non-iatrogenic and iatrogenic. Bleeding disorders, you have bronchial cyst, you have primary pulmonary embolism with pulmonary infection. Collagen vascular disorders, you have vasculitis, venous granulomatosis, and Goodpasture syndrome. So basically infections, you can remember TB, of course, hemoptysis is there, lung abscess also, hemoptysis, bronchiectasis, you don't remember bronchiectasis at all. Pneumonia, I can remember. Then traumatic also, you can say, because of doctor's activity and not because of doctor's activity. Neoplasm, of course, has bleeding, and bleeding disorders like bronchial cyst, and pulmonary embolism, one of the main features is hemoptysis. Okay, then cardiovascular disorders, you have mitral stenosis, pulmonary hypertension, aortic aneurysm, atriovenous malformation, and pulmonary embolism. All of these are cardiovascular disorders which lead to hemoptysis. Stenosis, of course, which we have discussed previously, yes, they do lead to hemoptysis. Winter cough, bronchiectasis, also they do lead to. Then pulmonary hypertension, similarity. I forgot the aortic aneurysm and atriovenous malformation and pulmonary embolism are some other causes of cardiovascular hemoptysis. So evaluation, you perform chest x-ray and you do fiber optic bronchoscopy and CT of chest. So treatment, you can treat the underlying cause. Massive hemoptysis is life-threatening. Attention should be given to airway, breathing, and circulation. And in massive hemoptysis patient, patient should be kept in lateral decubitous position with involved lung being in the dependent position. Involved lung should be opposite. So like if it should be lower. So then lung resection should be considered if bleeding site is localized and not responding to any medical measures. And you can so treatment is, you can also suppress the cough with the codeine syrup, and you can correct bleeding diathesis. Because cough is if the blood enters the bronchial wall and all, you cough means it will add pressure, undue pressure. That's the logic I feel. I'm not exactly sure. Nebulized adrenaline you can take, and also it causes pulmonary vasoconstriction and reduces the bleeding. Nebulized adrenaline. And tranexamic acid also you can take 500 mg. Okay, so hemoptysis, you have cough precedes hemoptysis, whereas hematemesis, nausea and vomiting precedes the hematemesis. It will be frothy due to admixture of air. Here it is not frothy. pH is alkaline. Here the pH is acidic. It is mixed with macrophages and neutrophil. Hemoptysis, it is only mixed with food particles in hematemesis. Melena is absent. Melena is present. Light red in color, dark red in color due to acid hematin. Previous history of respiratory disease is seen. Previous history of peptic ulcer disease is there, and it is diagnosed on bronchoscopy, whereas hematemesis is diagnosed by gastroscopy. So features, you have exudative and transudate. So pathogenesis, you have increased permeability in inflammatory condition, whereas transudates, you have ultrafiltration of plasma due to increased hydrostatic pressure with normal permeability. So it is non-inflammatory. So colors of the product, you have amber color in exudate, it is colorless in transudate. Consistency is 6, sticky in exudate, non-sticky in transudate. On shaking, froth will increase in both of them. On standing, the clot will occur in both of them. Specific gravity is more than 1.018 and it is less than 1.018. Cells is more in exudate, or in transudate there may be few lymphocytes. And you have Light's criteria, which is the most important thing. Pleural fluid pleural fluid protein by serum protein, and pleural fluid LDH by serum LDH, pleural fluid upper LDH. Those three are the criteria. Three criteria: pleural fluid, pleural fluid protein by serum protein. Then you have pleural fluid LDH by serum LDH. And you have finally upper LDH. X times serum. So you do all these three, whereas you need to remember 0.6, 0.5 and 2/3. If it is more and more in all of them, then it is exudative compound. If it's less in all of them, it is transudative compounds. Then glucose, if it is less than 60 mg or more than 60 mg. LDH, if it is less than more than 200 international units per liter or less than 200 international units per liter. You can have it checked. So pleural effusion is accumulation of serous fluid in pleural cavity. Causes, you have transudative cause, you have exudative cause. So in transudative cause, you have congestive heart failure, cirrhosis, pulmonary embolism, nephrotic syndrome, peritoneal dialysis, hypoalbuminemia, and atelectasis. Whereas in exudative, we have bacterial pneumonia, TB, malignancy, viral infection, collagen vascular disorders, Meeks syndrome, pulmonary embolism, gastrointestinal disease, you have esophageal perforation, pancreatic disease, and diaphragmatic hernia. So mechanism, you have elevation of venous pressure, there is decreased plasma oncotic pressure, and increased capillary permeability due to local inflammation, toxins or vasoactive substances. There is increased pleural space due to oncotic pressure and simple transfer of ascitic fluid across the diaphragmatic defects and through transdiaphragmatic lymphatics. Okay, look, there is elevation of venous pressure, then there is decreased plasma oncotic pressure. Plasma oncotic pressure will be decreased. Venous pressure will be increased, plasma oncotic pressure will be decreased. This leads to increase in capillary permeability due to local inflammation of toxins or vasoactive substances. They will infiltrate and they lead to increase in local inflammation. Then this leads to increase in pleural space oncotic pressures. In the pleural space, there will be an increase in the oncotic pressure. This will finally lead to transfer of ascitic fluid across the diaphragmatic defect and through the transdiaphragmatic lymphatics. And there is increased negativity of pressure in pleural space, which is atelectasis. Finally, you have obstruction of lymphatics. Atelectasis occurs, then obstruction of lymphatics. So again, atelectasis is one of the causes of transudative pleural effusion. So there will be an increase in venous pressure. Plasma oncotic pressure will decrease. Capillary permeability will increase due to local inflammation, toxins, and vasoactive substances. This leads to increase in pleural oncotic pressure. Then transfer of ascitic fluid across diaphragmatic defect and through transdiaphragmatic lymphatics will happen. There is increased negativity of pressure in the pleural space. Between the pleural space, there is increased negativity, and there is finally obstruction of lymphatics. All of them will lead to accumulation of serous fluid in pleural cavity. Mm, just a second. Uh, mm, shit. Okay. I just had to check something out. Mm, okay. So going on. Elevation of venous pressure. Basically, this is how there is pleural effusion. Bacterial pneumonia, TB, malignancy, viral infection, of course, infection of all kinds, collagen vascular disorders, Meek syndrome, which is right-sided hemithorax, ascites, and fibroid uterus, pulmonary embolism, Mm, cirrhosis and congestive heart failure will lead to transitive. Basically, all pathological stuff seems to be the same transitive. Exudative is seemingly more cell-related, Meek syndrome like pulmonary embolism, gastrointestinal perforation, and all those dirty stuffs will come. Yeah, I guess I can assume it like that. But nephrotic syndrome, peritoneal diagnosis, yeah, okay. So clinical features, you have symptoms and signs. Symptoms, you have pleuritic chest pain, dyspnea and exertion, peripheral edema, orthopnea, and proximal nocturnal dyspnea. Signs, you have stony dullness to percussion, decreased breath sounds over the effusion, trachea shifts to the opposite side, and egophony above the level of effusion. Pleuritic chest pain, of course. Dyspnea on exertion also is similar symptom. Pulmonary edema, peripheral edema, orthopnea on positional changes, proximal nocturnal dyspnea (PND), which is normal. What is it? Cardiovascular system symptoms. So signs, you have stony dullness to percussion. Stony dullness will be there. Decreased breath sounds over the effusion. Tracheal shift to the opposite side is there. Egophony above the level of effusion. Egophony about the level of effusion is there. Okay. So investigations, you have chest X-ray, you have blunting of costophrenic angle. Minimum 250 ml of fluid must accumulate before an effusion can be detected. So lateral decubitus films more reliable for detecting small pleural effusion. Then you have CT chest, thoracocentesis for evaluation of the fluid, glucose level, amylase level, differential cell count, pH of pleural fluid, immunoglobulins, and staining and culture can be performed. Thoracentesis is the process of drawing blood from thorax or blood or substances from the thorax. In that, you check the glucose level, your amylase level for if possible causes of cirrhosis and stuff like that. Amylase level, differential cell count, see the count, pH of the fluid, it may give an indication. Immunoglobulins, you have to check if there is any immunoglobulins, and staining and culture can be performed. So treatment of pleural effusion, you have transudative effusions, you can do diuretic and sodium restriction and therapeutic thoracocentesis in transudative. In exudative, you can do you can treat the underlying disorders. In parapneumonic effusions, pleural effusion in presence of pneumonia can be noticed. So you give antibiotics, you provide chest tube drainage, and you provide intrapleural injection of fibrinolytic agents like streptokinase, urokinase, and TPA, which accelerates the drainage, and surgical lysis of adhesions can be done. Then bronchial asthma, it is inflammatory disease of small airways characterized by episodic reversible bronchial obstruction due to hyper-responsiveness of tracheobronchial tree. Characterized by episodic reversible bronchial obstruction due to hyper-responsiveness of tracheobronchial tree. So you have types, you have extrinsic asthma and intrinsic asthma. Extrinsic is atropic early onset asthma, whereas intrinsic is non-atropic asthma, late onset asthma. So extrinsic occurs in childhood, intrinsic can be at any age, and extrinsic occurs at atopic individuals who readily form IgE antibodies in response to allergies. And intrinsic, there is no role for allergies in the production of disease. Then presentation, you have nocturnal asthma, overnight decrease of more than 20% in FEV1 or PEFR. So pathogenesis, you have early morning decrease in circulatory adrenaline. So early morning there will be decrease in circulating adrenaline. There is increased wiggle tone in the early morning. Airway cooling will occur at night, and circadian early morning disease in plasma cortisol concentration. That is the pathogenesis of bronchial asthma. So gastric asthma is dyspnea occurring only after meals due to gastro GERD. Exercise induced asthma is there, and episodic asthma is there. Patient has no symptoms between episodes of asthma. Okay, just a second. These are the different types of bronchial asthma. Inflammatory disease of small airway. Asthma is an inflammatory disease of small airway characterized by episodic reversible bronchial obstruction due to hyperresponsiveness in the tracheobronchial tree. That is the definition. You have extrinsic, intrinsic presentation. You have nocturnal asthma, gastric asthma, exercise-induced asthma, and episodic asthma. So yeah, a nocturnal asthma, an overnight decrease of more than 20% in FEV1 or PEFR, and pathogenesis is early morning. There is a decrease in circulating adrenaline. Increased vagal tone in the early morning, always cooling at night, airway cooling at night, and circadian early morning decrease in plasma cortisol concentration. Then you have acute severe asthma. It is a medical emergency. It is hypoxic. Patient is hypoxis and cyanos due to severe bronchospasm, characterized by tachycardia, pulse rate more than 120, tachypnea, respiratory rate more than 30, sweating, pulses paradoxus, where in more than 10 is abnormal, more than 20 is profound obstruction. You have altered consciousness. Inspiratory expiratory ratio is 1:4, whereas normally it is 1:2. In bronchial asthma, expiration is very much increased. Pulsus paradoxus is seen in severe asthma. Hypoxic cyanosed due to severe bronchospasm. Medical emergency, hypoxic cyanosed due to severe bronchospasm. Tachycardia is there. The increase in heart rate is there, more than 120. Tachypnea, with the respiratory rate is more than 30 per minute. It is having sweating. You're having sweating. You're having pulsus paradoxus, and you have altered consciousness. Then factors precipitating asthma. It may be cold air, tobacco smoke, dust, emotional stress, respiratory infection like viral and bacterial, exercises, drugs, NSAIDs, especially aspirin. You have Samter's triad, which is asthma, nasal polyps, aspirin sensitivity. That is Samter's triad. And drugs you can also provide beta blockers. Then you have allergens, which is ingested fish, nuts, and strawberries. Inhaled, you have dust, pollen, house dust mite. Occupational allergens, you have grain dust and wood dust. Dust due to grains and dust due to wood. Pathophysiology, you have chronic airway inflammation by cellular infiltration of airway, and you have release of mediators or eosinophils, mast cells, macrophages, and T lymphocyte. Bronchial smooth muscle contraction is noticed, denudation and desquamation of the epithelium, forming mucus plugs that obstruct the airway is also noticed, and airway remodeling by smooth muscle hypertrophy and hyperplasia, and goblet cell hypertrophy leading to mucus hypersecretion is also noticed. So airway remodeling, smooth muscle hypertrophy and hyperplasia is noticed. Goblet cell hypertrophy leading to mucus hypersecretion is noticed. Collagen deposition leading to thickening of lamina reticularis is noticed. Cellular infiltration and edema is also happening. So clinical features, you have widespread polyphonic, high-pitched voice will be there. You have mild bronchoconstriction leading to expiratory wheeze. You have moderate bronchoconstriction leading to inspiratory and expiratory wheeze. And you have severe bronchoconstriction wherein you have only inspiratory wheeze. So you have widespread polyphonic, high-pitched wheeze. Mild you have expiratory wheeze, moderate you have inspiratory and expiratory wheeze, and severe you have only inspiratory wheeze. Then moving on, you have tachypnea, which is increase in breathing. You have diaphoresis, patient will be sweating a lot, and use of accessory muscles of respiration. Okay, before I move on, let's just confirm of the pathophysiology. So there is chronic airway inflammation by cellular infiltration of the airway. Airway, there will be cellular infiltration. Then you have release of mediators from eosinophil, mast cells, and T lymphocytes. This causes bronchial smooth muscle constriction. This leads to denudation and desquamation of the epithelium, following a mucus plug that obstructs the airway. And finally, the airway also will undergo remodeling. So smooth muscle hypertrophy and hyperplasia is there. Then you have goblet cell hypertrophy leading to mucus hypersecretion. Collagen deposition is there leading to thickening of lamina reticularis, and cellular infiltration and edema is also noticed. Okay, so yes, we go on. Differentials literally TB, asthma, COPD, bronchial asthma, aspergillosis, allergic bronchial bronchopulmonary aspergillosis, systemic vasculitis. All those you can write on your own. COPD is enough. COPD and TB is enough. So diagnosis, you have a pulmonary function test where you see a obstructive pattern where there is decrease in expiratory flow rate, decrease in FEV1, decrease in FEV1 by FVC ratio. Then you have spirometry, peak expiratory flow rate, broncho provocation test using methacholine, chest X-ray, hyperinflation, and arterial blood gas, blood arterial blood analysis. You can find hypocarbia due to hyperventilation and hypercarbia due to respiratory muscle fatigue or severe airway obstruction. So moving on, pulmonary obstructive pattern is that decrease expiratory flow rate, decrease FEV1, decrease FEV1 by FVC ratio less than 0.7. Then you have spirometry, you have to do. Then you have peak expiratory flow rate, which will be reduced, and bronchoprovocation test can be done with methacholine, and chest X-ray will show hyperinflation, and arterial blood gas analysis. You have hypocarbia, decrease in carbon dioxide because of hyperventilation, and hypercarbia is a sign of respiratory muscle fatigue or severe obstruction. So if they are not able to remove the carbon dioxide, then it becomes hypercarbia. That's the basic gist. 1 second. Okay. So management, you have drugs for bronchial asthma. So in these drugs for bronchial asthma, you have all these drugs. So first you have bronchodilators. Bronchodilators are beta sympathomimetic drugs, methylxanthines and acetylcholine. So what do you say, salbutamol, terbutaline, benbuterol, all LAL drugs. Salbutamol and terbutaline is most common, and formoterol and salmeterol. So you have two short acting and you have a few long acting drugs. So salbutamol is a short acting, terbutaline also short acting, and salmeterol and formoterol are long acting. That you should remember the classification. Then you have methylxanthines, where you have thiophylline and aminophylline. So yeah, the way beta blockers work is they are bronchial smooth muscle relaxant and their first line therapy, whereas in methylxanthine they are second line therapy and they inhibit diesterose enzyme diesterase enzyme. Okay, then you have anticholinergic, which is ipratropium bromide and tiotropium bromide. They are add-on. They are useful in very severe cases and with patient with heart disease. They are slow to act and they have a modest efficacy. Okay, then moving on, you have leukotriene antagonist like montelukast and zafirlukast. They inhibit the release of leukotrienes, which mediate airway inflammation. So montelukast and zafirlukast inhibit leukotrienes and modify the airway inflammation. They decrease the inflammation. Okay, less leukotrienes are released, less inflammation is produced. So inflammation will be decreased. Then you have mast cell stabilizers. You have sodium chromoglucate and ketotifen. They prevent degradation of mast cell. Therefore, there is no release of mediators. Okay. Then corticosteroids. You have two types. You have systemic and you have inhalation. In systemic, you have hydrocortisone, prednisolone, and other glucocorticoids, whereas inhalation, you have betaclopramide, dipropionate, budesonide, fluticasone. All of these can be provided. However, they decrease airway inflammation. However, it is not to be abused because of side effects. Then finally, you have omalizumab, which neutralizes circulating antibodies, IgE. It reduces the number of exacerbation in patients with severe asthma. So in patients who have very severe asthma, they do not have so much exacerbation. This is anti-IgE antibody. Okay, so moving on, treatment is based on the severity. So there is also a naming scheme which I'm forgetting. It's provided basically the gist is principle is lowest dose shortest period of time. Okay, so it should be like you have to provide the lowest dose and the shortest number of times that you need to be providing that dose to be effective, like to treat the asthma. So based on the severity, you have very intermediate asthma, less than 1 week, no need for, or maybe just inhaled as SABA is good. Mild is more than one time per week, inhaled corticosteroids, thiophylline and nidocromil. 1 second, is there a nidocromil here? Why do they recommend nidocromil here? Inhaled corticosteroids, yes, makes sense. No idea why they have written nidocromil here. I don't even know which drug nidocromil is. Well, let's check it out once. mast cell stabilizer, similar to Montelukast. Montelukast and Staphylococcus, basically. That is for mild cases. In moderate cases, you need an inhaled corticosteroid, some 800 to 2000 microgram they have given here. Some quantity, this might not be correct. Do not trust this. And you can have LABA, inhalational or tablets, and leukotriene inhibitor add on if it is very much not controlled and very severe. Moderate and severe, you have it is continuous, it is throughout the day. You have to provide inhaled corticosteroids, you have to provide LABA, you have to give another tablet of inhaled corticosteroids and omalizumab inhibitor add on. So whereas previously you can add just the nidocromil or maybe Montelukast and relax, you need to add omalizumab here. So management of acute severe asthma, high concentration of oxygen therapy, high dose beta 2 agonist against nebulization. Through nebulization, I dose through nebulization at least 3 times in first hour. You have to give nebulization and you have to give beta 2 agonist in nebulization. Then you have to provide systemic corticosteroids. Methylprednisolone you can give 40 to 60 mg every 6 hours for 2 days, and IV aminophylline also can be provided. Terbutaline injection and subcutaneously can also be provided. So in refractory cases, you have ipratropium bromide nebulization or aminophylline IV. You can provide in 20 minutes. Then monitor treatment, you have pulse oximetry and assisted ventilation when needed. 70 to 80% of helium, in which is a balanced oxygen, can be provided. It reduces airway resistance and improves the effect of bronchodilator. Then FEV1 is the amount of air that can be forced out of the lung in 1 second. FEV, number of seconds, 1. Staphylococcus muscles include 4 infra hyoid muscle. You have staph muscles. Sternocleidomastoid, omomyhyoid, thyrohyoid. Sternocleidomastoid, I don't know. This entire thing doesn't make sense. What is written here? I've left it. Okay. Finally, then we move on to what is one of the most difficult question to answer in this exam. COPD, which is expiratory airflow limitation, not fully reversible. So COPD includes chronic bronchitis, emphysema, and small airway disease. Small airway disease, asthma also kind of comes in, I think so. They kind of explain it in a weird way. So COPD is a common, preventable, treatable disease characterized by persistent respiratory symptoms and airflow limitation due to airway and alveolar obstruction usually caused by significant exposure to noxious agent gas particles. So you have a gold standard where it is Global Initiative for Obstructive Lung Disease, chronic obstructive lung disease. So predisposing factors for COPD, you have smoking, environmental pollution, dust and smoke, genetic predisposition. Oh, okay. Wait, just a second. Is this the cause? Is there something here? Yeah. No, there's some error happening with the application. And I think I could have sworn I had an error like this before also. Okay, so smoking, environmental pollution, dust and smoke, genetic predisposition is there for COPD, and infection, bacterial or viral. Brother, I mean it's there, but I think the maximum number of times I can use the make a correction on this is reached. Okay, wait, I just be back. Give me a second. Okay, it seems to be fixed itself. So let's check it out. Okay, so infection, it can be, of course, a bacterial or viral infection. Usually it predisposes to COPD. It acutely exacerbates it also. And alpha 1 antitrypsin deficiency can be provided for emphysema. Occupational exposure, you have fumes, etc., and exposure to sudden change in the temperature. Then pathogenesis. So you have a chronic bronchitis, emphysema, and they forgot to mention the small airway disease. Okay, so chronic disease, it is chronic bronchitis is excessive tracheobronchus mucus production leads to narrow airways and productive cough. It is seen for at least 3 months of a year and often for more than 2 consecutive years. So emphysema, you have distension of air spaces distal to terminal bronchiole with destruction of alveolar septa. Destruction of alveolar wall leads to excessive release in relative excess in protease like elastinase, which is released from polymorphonuclear neutrophils and macrophages. There is relative deficiency of antiproteinase of alpha 1 antitrypsin activity in the lung, and tobacco smoke increases and activated polymorphonucleosides and macrophages. So there is changes in airway, parenchyma, and vasculature. And elastase will inhibit the alpha 1 antitrypsin and increases the oxidative stress by free radical. Okay, so distension of airways, terminal, destruction of alveolar septa, destruction of valves due to relative excess in protease released from this, and relative deficiency of protease. Alpha 1 antitrypsin is deficient in the lung. Tobacco smoke will increases activated polymorphonuclear neutrophils and macrophages, and elastase inhibits alpha 1 antitrypsin. So types of emphysema, you have centriacinar, panacinar, and paraseptal. So centriacinar involves only proximal part of respiratory unit, which is sinus. There is uniform destruction and enlargement of sinus, alpha 1 antitrypsin deficiency, and paraseptal involves only in the distal sinus. So centriacinar involves only the proximal part of the respiratory unit, sinus. Panacinar acinar involves all of the sinus. What is this? Sinus. Paraseptal is only involving the proximal sinus. There is also another thing, I think so. Irregular also is there. Give me a minute, my throat's paining. Why are you suddenly paining so much? Okay, so I'm back. Let's go. So we have varieties of emphysema. First we had the types of emphysema, then we have the variety of emphysema. Very awkward. Okay, so we have compensated emphysema and mediastinal emphysema. Compensatory emphysema, wherein the normal lung tissue undergoes compensatory hyperinflation on due to response to damage in a part of same or opposite lung. So alveolar septae will be reserved. Then mediastinal emphysema is escape of air rapidly into the mediastinum following rupture of over distended alveoli. So escaped air enters the subcutaneous tissue leading to subcutaneous emphysema. So clinical features and symptoms, you have cough is predominant in chronic bronchitis. Sputum production is there and dyspnea is seen with predominant which is predominant in emphysema. So signs, you have prolonged expiratory time with pursed lip breathing, so that there is a positive PEEP, post expiratory end pressure. So auscultatory, you have end expiratory wheeze, which is decreased breath sound, and inspiratory crackles is there. Then for percussion, you will be having hyperresonant note will be heard. Tachypnea is there, tachycardia is there, cyanosis, and uses of accessory muscles of respiration. So there is also signs of cor pulmonale. Finally, you have predominant emphysema and you have predominant chronic bronchitis. So predominant emphysema are pink puffers and chronic bronchitis are blue bloaters. So the patients are thin in emphysema, patients are overweight and cyanotic in blue bloaters. Fat, blue and thin. There is increased energy expenditure during breathing, and secondary to hypercapnia and hypoxia, the cyanosis occurs. Then patient will lean forward while sitting. Chronic cough with expectoration is seen in predominant. Okay, wait, no, this is not comparing. Comparing point is only one. Okay, patient will lean forward while sitting. Patients have a barrel chest. There is increase in AP diameter, and they use accessory muscles. Okay, and in chronic bronchitis, there is chronic cough with expectoration, and there is signs of cor pulmonale in severe long-standing cases. There is no use of accessory muscles. And the complications, you have pneumothorax, you have cor pulmonale, you have respiratory failure, and acute exacerbation also may be there. You have secondary polycythemia, which is compensatory to chronic hypoxia. So there is chronic hypoxemia, therefore it will lead to secondary polycythemia. Oh my god. So okay, investigations, few spirometry is there. You have to do presence of post bronchodilator FEV1 less than 80%, and FEV1 by FVC is less than 70%. Chest X-ray, you have hyperinflation, you have flattened diaphragm, and you have enlarged retrosternal space. Then you measure alpha-1 antitrypsin levels. Then arterial blood gas analysis, you have partial pressure of carbon dioxide retention and oxygen decreased. Then Reed index is also there, wherein the ratio of submucous glands to bronchial wall is noticed. You have normal individuals in which it is 0.44, and in chronic bronchitis you have 0.52. These numbers you have to remember. Luckily 44 and 52. Okay, it's possible to remember. Somehow you have to remember this. Arterial blood gas analysis, P carbon dioxide, hypoxia, compensatory chronic hypoxemia. Right here they have mentioned. Right, actually. Yeah, chronic hypoxemia. One second. Let me. Oh, yeah. Okay, so investigation spirometry. You have FEV1 less than 80%, FEV1 by FVC less than 70%. It is similar in here, FEV1 by FVC less than 70%. Same thing for asthma and COPD, you can remember. Then you have arterial blood gas analysis, PCO2 retention. Measure alpha 1 antitrypsin levels for emphysema, and chest X-ray you will be seeing hyperinflated, flattened diaphragm, and enlarged retrosternal space. Behind the sternum, space will be enlarged. And treatment going on, you have vaccination for influenza, streptococcus pneumonia, and non-invasive positive pressure ventilation if the patient is hypoxemic. So COPD medication, you have three types: anti-inflammatory medication, inhaled bronchodilators, and miscellaneous. So in anti-inflammatory medications, you have corticosteroids, inhaled fluoroconazole, budesonide, etc., and systemic prednisolone, methylprednisolone, etc., can be provided. And the side effect is candidiasis, osteoporosis. This is an important thing to remember. Then you have PD. Yes, I think. What is PD? PD inhibitors? Prostaglandin, no. Give me a second. What is PD inhibitors? 1 second. PDE inhibitors. Phosphodiesterase inhibitors, they block the action of PDE enzyme, leading to increased levels of cyclic nucleotides, cyclic AMP, cyclic EMP, which in turn causes vasodilation and smooth muscle relaxation to treat various conditions. Okay, those are PDE inhibitor. Non-selective, you have thiophyllin, and selective PDE4, you have roflumilast. And inhaled bronchodilators, you have bronchodilator agonists and inhaled anticholinergic drugs. So bronchodilator inhaled beta agonist, you have short-acting beta agonist, SABA, salbutamol. I don't know why they have written albuterol, it's salbutamol. And long-acting beta agonist, salmeterol, formoterol. And inhaled corticosteroids, you have short-acting corticosteroids, ipratropium, and you have long-acting tiotropium. And miscellaneous, you have antibiotics. You provide smoking cessation medication, immunization you can provide, home oxygen therapy also can be provided. So other the medication, you have IV alpha-1 antitrypsin, influenza pneumococcal vaccination, and pulmonary rehabilitation and aerobic physical exercises. Then mechanical support, you can give COPD with aspirosis, like respiratory failure. You can provide mechanical ventilatory support. Non-invasive positive pressure ventilation can also be provided. So surgery for COPD, you have lung volume reduction surgery, you have bulectomy, and lung transplant in advanced cases. So what else can you say? Okay, bronchiectasis surgery, yeah. Lung volume reduction surgery, bulectomy. If there is a bulla, you can remove it. You can make an incision, remove it, then patch. And a lung transplant in advanced cases of COPD. Generally, lung transplant is cool, yo. Lung transplant and brain transplant, two of the most coolest transplant. But that's sidetracking with Sanam. So, okay, bronchiectasis, persistent, irreversible dilatation of medium-sized bronchi, 5th to 9th generation by more than 2 mm. You have congenital or acquired, localized or diffuse. Those are the bronchiectasis. Persistent, irreversible dilatation of medium-sized bronchi, 5th to ninth generation by more than 2 millimeter. Okay, so it is caused by recurrent infection, cystic fibrosis, which is the most common cause, primary ciliary dyskinesia like Carragher syndrome, autoimmune disease like rheumatoid arthritis, SLE, Crohn's disease, etc., and humoral immunodeficiency. So, pathogenesis, you have destructive and inflammatory changes in walls of medium-sized airways. You have inflammation leading to upregulation of enzymes, elastase, and matrix metalloprotease. Elastic tissue is destroyed and replaced by fibrous tissue, and dilatation of airway is seen. So, first destruction of changes in the wall and medium-sized airways will occur. Then inflammation, upregulation of enzymes will be there. Elastase and matrix metalloprotease will be upregulated. Elastic tissue is then destroyed and replaced by fibrous tissue, leading to dilatation of airway. So, types you have cylindrical, saccular, which is cystic, and varicose. Clinical features, you have chronic cough with mucopurulent foul sputum. You have dyspnea, hemoptysis will be there, wherein there is a blood vessel rupture near the bronchial wall surface. Recurrent or persistent pneumonia is there. Upper lobe bronchiectasis, which involves the apical segments, TB, cystic fibrosis, and ABPA is there. Dry bronchiectasis, which is bronchiectasis sicca, wherein only hemoptysis is present and no sputum production, TB occurs. Then you have middle lobe bronchiectasis, which is Brock syndrome, wherein there is recurrent atelectasis of right middle lobe in absence of endobrachial obstruction by TB lymph nodes. Okay, so pseudo reversible bronchiectasis is temporary bronchial dilatation in area of lung affected by pneumonic consolidation and tracheobronchitis and lung collapse. Hmm. 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 So complications, you have hemoptysis, metastatic abscess, brain, pericardium, etc., pneumothorax, carpulmonale, recurrent pneumonia, pyothorax, and lung abscess. This is bronchiectasis. It is similar to a little bit. Yeah, metastatic abscess, carpulmonale is similar. Okay. Pneumothorax, of course, bronchiectasis, if there is a connection between the enlarged bronchiole and the lung and the in between space, then there is pneumothorax. Carpulmonale, of course, right side. Metastatic abscess in brain and pericardium due to spread. Recurrent pneumonia, yeah, okay. Pyothorax and lung abscess. Abscess is common because of it's a infective cause. Inflammatory changes is there, infections and all is there, recurrent infection. Cystic fibrosis is most common cause, okay. And primary ciliary dyskinesia, autoimmune, and hormonal immunodeficiency. Okay. Cylindrical, saccular, and varicose. Varicose, I don't know how to draw. Oh, leave it. Chronic cough with mucopurulent, foul-smelling sputum is there. Chronic cough, mucopurulent, foul-smelling sputum. Dyspnea is common. Hemoptysis, rupture of blood vessels near the blood surface, in the surface. Recurrent persistent pneumonia, of course. Upper lobe bronchiectasis, apical turbinate, CDB, cystic fibrosis, and ABPA. What is ABPA, man? Honestly, not even required. I'll just scratch it out. Okay, dry bronchiectasis sicca, only hemoptysis is present, no sputum production is there. Middle lobe bronchiectasis is also called as Brock syndrome from Pokemon, who was inspired this. And recurrent atelectasis of right middle lobe will be there. Middle lobe bronchiectasis, recurrent atelectasis, weakening of the bronchial wall of the right middle lobe, and there is shrinkage of entire lung in absence of endobrachial obstruction by TB lymph nodes. There's no endobrachial obstruction due to TB lymph node. So pseudo, you have reversible bronchiectasis, temporary bronchial dilatation in area affected by pneumonic consolidation, tracheobronchitis, and lung collapse. Okay, so moving on, diagnosis. You have chest X-ray, CT scan, diagnostic study of choice, PFTs, which is obstructive pattern, and bronchoscopy. So chest X-ray, it is from what is it? Tram track appearance of thickened bronchi is seen, bilateral honeycombing shadows is seen, and cystic lesions are seen. So bilateral appearance of thickened bronchi. Bronchi will appear thickened bilaterally. Bilateral honeycombing shadows will be seen, and cystic lesions will be apparent. Okay, so cystic fibrosis, cystic lesions will be apparent. Honeycombing shadow. Somehow you need to remember honeycombing shadow. Okay, moving on. Treatment: antibiotics for acute exacerbation, hydration, chest physiotherapy. You have postural drainage and chest percussion to help remove the mucus. You tap the chest and allow the mucus to get dislodged. You do this every morning and remove all the dirt and shit. Inhale bronchodilators to dilate the bronchioles. And main goal in treating bronchiectasis is to prevent complication of pneumonia and hemoptysis. Then you have surgical resection, bronchial airway embolization. It is yearly influenza virus. You need to take replacement and therapy in alpha-1 antitrypsin. Deficiency, if it's there, you have to provide replacement and therapy. So moving on, we have just a second, pneumonia we have to do, TB we have to do, and bronchogenic carcinoma, yes, pulmonary embolism, very big, pneumothorax, okay, pneumothorax and cystic fibrosis, of course. Tropical pulmonary eosinophilia. This is a simple one. This is pulmonary eosinophilia. It is anaphylactic response due to W. Wuchereria bancrofti and B. malai. This causes this tropical pulmonary eosinophilia. There is cough, nocturnal bronchospasm, miliary pulmonary infiltrate similar to TB, splenomegaly will be there, lymphadenopathy will be there. So diagnosis: peripheral blood eosinophilia is more than 3000 per ml, high titers of filarial antibody, IgE levels is more than 1000 units per ml. So management is DEC, which is for the filarial worms, H2 blockers, lutein LK inhibitors, lutein inhibitors, what are the name? Omalizumab, but leukotriene inhibitors, omalizumab is IgE inhibitor. Noradamil is, of course, montelukast. Leukotriene inhibitors, no, I just forgot. Okay. Leukotriene inhibitors, you have montelukast affinicast. Okay. I got confused. I thought this was here and this was here. Like this one to this, I got confused with the names, and there's a reason why the problem occurred. Okay, no chromil. Okay, fine. I'm going to end the stream right now. I'm a little bit tired. I'll take a little break and I'll come back and I'll stream a little bit more. So yeah, okay.